Okay, so I think we are live. I have like 114 pages to do, and my way I'm thinking, I don't really, I don't really think I can finish the entire thing, but I don't know what I'll do. I don't have to finish the entire thing. That is Pakka sure. I feel this is the only day that I have to finish the entire thing, but it takes like 1 hour to do 10 pages, and I have like 14 plus 14 plus 8, so that's like an entire day of just talking, which usually isn't a problem, but your motivation kind of goes down once you realize that you're talking alone. But no, I'll try to convince myself some cute lady is there in my chat. In watching this video, my only motivation is like someone cute is watching this, right? And it might be fun to speak with them sometime. Who knows? If I'm the Pakka tour, like if I finish reading the entire thing, at least one person will be there who might like this. Okay, fine. So, inflammatory bowel diseases, they are from inappropriate bowel mucosal response to normal gut flora, more common in female, more common in developed countries. And hygiene hypothesis, reduced frequency of normal enteric infection. So, Crohn's disease is regional enteritis, transmural infection. Ulcerative colitis is confined to mucosa and submucosa. So, IBD is due to host interactions with the gastrointestinal flora, intestinal epithelial dysfunction, and aberrant mucosal immunity. Crohn's disease is a chronic transmural non-caseating granulomatous inflammation of the intestine. It is most common in terminal limb, but it can affect literally every single other part. It is Mycobacterium paratuberculosis, HLA-DR1, involvement of working diet, and bacterial dysbiogenesis. Pathology. So, multiple areas of transmural infection. You have skip lesions, granuloma formation. Cobblestone appearance is a string sign of contour is there, wherein you have thickening of the bowel wall and you have formation of stricture, fistula, and fistula. So clinical features: you have diarrhea, right lower quadrant pain. You have malabsorption, malnutrition. You have loss of albumin, iron deficiency anemia, B12 anemia, extra intestinal manifestations. You have erythematosa, uveitis, arthritis, ankylosing spondylosis, nephrotic syndrome, sclerosing cholangitis, gallstone amyloidosis, blood anemia. All these symptoms you have malabsorption, loss of so complications, of course, you have stricture formation, perforation, bleeding, fistula formation, and colonic adenocarcinoma. These are having like single. This is more common. Fistula is more common. Stricture is okay. And perforation, bleeding, of course. These are all not seen in ulcerative colitis. And special feature is rectum is spared, whereas in ulcerative colitis rectum is always involved. Proctitis. Yeah. You have serpentine ulcers. Differential diagnosis, nobody cares. Investigations, you do a plain x-ray, you ultrasound abdomen, barial meal study, you have terminal ileum stenosis. So it is the string sign of Cantor. You have CT scan, you have colonoscopy. So serpentine ulcers, skin lesions, cobblestone appearance. Then you have capsular endoscopy, MRI, enterosalpingogram. lysis, and you have screening test, which is presence of ASCA. Anti-cytometers cerevisiae antibody. This might be the only important thing which I don't know. Capture endoscopy, yeah. MRI enterocellulitis to demonstrate the fistula. Okay, so drugs, you have total parenteral nutrition, steroids which induces remission, azathioprine for immunosuppression, infliximab for monoclonal antibody. Surgical treatment, you have ileocecal resection and right hemicolectomy, and total colectomy and ear rectal anastomosis. All those can be done for Crohn's disease. Then you have ulcerative colitis. This is an inflammatory condition of rectum and colon. Starts in rectum, spreads proximally to colon. Pancolitis and ileum backwash ileitis. So etiological factors, their consumption or large amount of red meat. Immunologically, it is HLA DR2, whereas this one is HLA DR1. You have allergy to dietary factors, stress, smoking, alcohol, and defective mucin production in colonic mucosa. And you also have appendicectomy and smoking as protective agent against ulcerative colitis. So here is basically mucosal and submucosal inflammation, no skip lesion, there is stricture of the colon. You have a permanently contracted colon, lead pipe appearance. And you have epithelial thickening between the ulcers. So clinical features, you have bloody mucoid diarrhea, tenesmus, itching, right lower quadrant pain, abdominal distension, severe malnutrition and hypoproteinemia, and uveitis, ankylosing spondylitis, sclerosing cholangitis. Complications, you have pseudopolyps, colonic adenocarcinoma, stricture, massive hemorrhage, and toxic megacolon. Toxic megacolon is one of the things which is seen only in ulcerative colitis and not in Crohn's disease. Then, as far as investigations goes, you have to do a plain X-ray which shows obstruction, toxic megacolon, and perforation. Barium minima will be having a lead pipe appearance. Sigmoidoscopy and biopsy can be done, and colonoscopy can be done. Treatment is again TPN, correction of anemia, steroids which induce remission, immunosuppression, infliximab for monoclonal antibody, and mesalamine, which is NSAID, I think so, I'm not sure, but yeah, same for both. So surgery, you can do total proctocolectomy with ileoanal anastomosis, or you can do total proctocolectomy with ileostomy. Basically, you remove the rectum. So you have the difference between Crohn's disease and ulcerative colitis. Most common site, distribution, rectum and colon, backwater ileitis also can be seen. Spread, discontinuous, gross features, you'll be having linear features, cobblestone appearance, thick and bowl wall, whereas here you'll be having pseudopolyps, you'll be having extensive ulceration, you have a toxic megacolon and lead pipe appearance. So microscopically it is non-caseating granuloma, here it is crypt abscess. Inflammation is transmural, it is limited to affects all the layers, whereas here it is in ulcerative colitis it is limited to mucosa and submucosa. Complications, you have string sign, obstruction, abscess, fistula, sinuses, strictures, etc. Whereas here you have toxic megacolon. Genetic association, HLA-B27, HLA-DR1 and DR2. Extraintestinal manifestations, it is common. Arthritis, spondylosis, primary sclerosing cholangitis, erythema nodosum, pyoderma granulosum, and uveitis. Whereas in ulcerative colitis, it is also common. Same thing, literally go towards same thing, you can see. Cancer risk is slight in Crohn's, but in ulcerative colitis it is strong. Then Whipple's disease. Whipple's disease is basically malabsorption disease. It involves multiple organs, and it is due to gram-positive bacteria Trophima whipple. So endocytosis of bacteria into macrophages in small intestine. Endocytosis. This causes lymphatic blockage in lamina propria of small intestine, causing malabsorption. So it leads to diarrhea, chronic migratory non-destructive polyarthritis, weight loss, abdominal pain, distension, tenderness, ophthalmoplegia, and dementia myoclonus, generalized lymphadenopathy, skin pigmentation, and you have cardiac involvement, which is mitral and aortic regurgitation. So investigations, you have elevated ESR and CRP. Test for malabsorption you have to do. Jejunal biopsy you can do. Biopsy of other tissue, you have PAS, periodic acid Scuffed, positive macrophages that contain small bacilli. PCR test for TVP antigen in any part. So treatment is ceftriaxone, meropenem, amipenem, meropenem, all those drugs. Ceftriaxone, of course, it is followed by oral trimethoprim sulfasilazole BID for 1 year. Treatment should be taken for 1 year. Then we move on to abdomen. TV is not that important. IBS is important. This is a question mark because I really don't think this is important. Basically commonly affects ileocecal region, increases physiological stasis, rate of fluid absorption, minimal digestive activity, and abundance of it is caused by M. tuberculosis, hematogenous spread from primary lung foci, ingestion, direct spread adjacent organs, and lymphatic spread from infected nodes. So peritoneal TB is spread from lymph nodes, intestinal lesion, TB self-anxiety in female. Pathologically, it is of 3 types: ulcerative, hypertrophic, ulcer-hypertrophic. So again, clinical features: fever, pain, diarrhea, constipation, weight loss, anorexia, abdominal distension, papulomas in right iliac fossa. This is common. Complication, of course, hemorrhage, perforation, subacute intestinal obstruction, fistula formation, malabsorption, because it is having a rapid increased electrolyte absorption and physiological stasis. Investigations, you have raised ESR, CXR shows total TB, abdominal X-ray, calcified lymph nodes, dilated bowel loops with multiple air-filled fluid levels due to obstruction, air end of the diaphragm. All those can be seen. And barium meal hyperosmolality increases the accelerated intestinal transit. Hypersegmentation of the barium column leads to chicken intestine. Multiple structures, Sterling sign which is failed. This is segment to retain barium, and string sign, thin beam of barium in the terminal ileum, same as in Crohn's disease. Ulcerative multiple strictures with segmental dilatation of bowel loops. Chicken intestine. Okay. Barium enema. You have inverted umbral sign, wide gaping of ileocecal wall with narrowing of the terminal ileum. It looks like an umbrella, inverted umbrella. Then you have gooseneck deformity, which is loss of normal urine. Ultrasound, CECT, cytic fluid examination, colonoscopy. So treatment, you have anti-TB drugs and stricturoplasty, treatment of perforation. This entire thing is important. This entire thing. Okay, it is small. So going on, this is an important question. A lot of times, a lot of eye markers come for irritable bowel syndrome, and is there HIV in this? Just sorry, hepatitis B. Apparently no. I mean, all of these are very much important, but rheumatology I'm skipping, bro. I just got no time. Fine, let's just finish this as fast as possible. So, irritable bowel syndrome is a chronic symptom, altered bowel habits, and abdominal pain without any organic cause. Anxiety, stress, GI motility altered. It is relieved with defecation associated with change frequency of stool, associated with changing consistency of stool. So investigations, stool examination for leukocyte, ova, parasites, bacteria. You can do sigmoidoscopy, barium minima examination, upper GI, small intestine endoscopy, and gallbladder ultrasound. Abdominal CT exams can also be done. So management is with reassurance, stress reduction, low dose tricyclic acid, increased dietary fiber, and anti-diarrheal agents. Workers nodule will come as a 3 marker left supraclavicular node, palpable in GIT malignancy and pelvic malignancy. It is called Drosier's sign. That is the only thing which you require. Upper GI endoscopy indications dysphagia, gastric or foreign body ingestion, dyspepsia, persistent nausea and vomiting, small intestine biopsy, acute or chronic gastric bleeding, IBD associated with duodenal lesions. You can mimicking a duodenal ulcer, and chronic abdominal pain, suspected polyp or cancer. It is contraindicated if suspected perforation, patient in shock, uncooperative, and severe inflammatory bowel disease or toxic megacolon. So it is not indicated in those. Complications, it may be perforation, bleeding, cardiac arrhythmias, sclerosants, and vasovagal reaction and pulmonary aspiration. Then Plummer-Wilson syndrome is dysphagia initially to solids, later to liquids, esophageal whips, due to esophageal whips. Iron deficiency, microcytic hypochromic anemia, koinonia, atrophic glossitis, and increased risk of post-rheumatoid carcinoma. Then let's move on. We have a topical sprue, which is idiopathic tropical malabsorptive syndrome. So malabsorption occurs in the patients of tropics, occurring in patients of tropic in absence of other intestinal disease or parasites. So etiologically, it can be an infective organism, E. coli, Klebsiella, Enterobacterium, or it can be folic acid deficiency. So clinical features, you have 3 phases. Initial phase, active diarrhea, intermediate phase, and last phase, where you have frank malabsorption. Idiopathic tropical malabsorptive symptom, E. coli and all infection, folic acid deficiency, diarrhea, abdominal distension, anorexia, weight loss, glossitis, and stomatitis. Investigations you do for pathogens, stool examination, megaloblastic anemia, hypoalbuminemia, impaired tests of absorption because it is malabsorptive syndrome, and you do jejunal biopsy. Partial villus atrophic emission. So the treatment is tetracycline 1 gram for 6 months, folic acid 5 mg daily, correction of defective whatever is defect, symptomatic treatment for diarrhea. Then you have carcinoid syndrome caused due to the what is this? Release of vasoactive substances by carcinoid tumor. So all these substances are released by the carcinoid tumor. Serotonin acts on smooth muscle, causing this diaphosis, bradykinesia, histamine, prostaglandin, Bradykinin and histamine leads to flushing through their vasodilator effect. Prostaglandins, of course, just exist. And carcinoid tumors are neoplastic proliferation of enterochromaffin cells. So whereas before we talk about topical sprue, we have celiac disease, which is non-topical sprue, gluten-induced enteropathy. Celiac disease is a chronic intestinal disease causing malabsorption due to gluten intolerance. So immunologically, it is damage of mucosa due to gluten protein, gliadin of wheat, barley, and rye, associated with HLA DQ2 and DQ8. So clinical features: you have chronic diarrhea and steatorrhea, abdominal pain, bloating, pruritic rash on external extensor surfaces, which is dermatitis herpetiformis, LFT abnormalities, liver function test abnormalities, iron deficiency anemia, fat soluble vitamin deficiency, early onset osteoporosis, strong association with type 1 diabetes mellitus. So investigations, you can do a serological test, IgA anti-endomycin antibody against endomycin antibody, IgA anti-tissue transglutaminase antibody, okay, IgA anti-gliadin antibodies. I can do general biopsy for partial villus atrophy, which is same in only as a topical sprue, and you get two tests for absorption. These both are same, whereas serological tests are different. Here you can have pathogen, here you don't have pathogen, so you have to do IgA against endomycin antibody, anti-tissue transglutaminase, IgA against anti-gliadin antibody. So treatment, of course, is gluten-free diet, dapsone for dermatitis herpetiformis, and vitamin and mineral supplementation. You have Gardner's syndrome, which is familial adenomatous polyposis. It is an autosomal dominant disease. You have multiple adenomatous polyp through the colon. You have hundreds of polyps by the age of 50 years. It results in germline mutation of APC gene on chromosome 5. Investigations, you have to do colonoscopy and genetic testing for all first degree relatives and total proctocolectomy with ileal pouch anastomosis you have to do, and you can do like selective COX-2 inhibitor to reduce the edema burden, and you can do sulindac, which is an NSAID which reduces the size and number of adenomatous polyp. So going to hepatology. So you have this simple chart for bilirubin and stuff like that. Normal RBC, it become senescent RBC, which leads to formation of hemoglobin. Globin will enter the protein pool. Heme will be converted to biliverdin, bilirubin and Albumin will become unconjugated bilirubin, and bilirubin glucuronides is similar to conjugated bilirubin. It will be conjugated in the liver, whereas all the other breakdown product will happen in mononuclear phagocyte. Again, 95%, 85% normal RBCs, 15% occur in bone marrow, immature RBCs, myoglobin, extra erythroid, and erythropoiesis. So conjugated, once it is conjugated, it is in the blood, it is unconjugated. It will become conjugated in the liver. It will get excreted as conjugated bilirubin. It is converted to urobilinogen in the intestine, and 80% is excreted as stercobilinogen and stercobilin in the stool. The duodenum, in the duodenum, 20% of the urobilinogen is formed in the intestine, is reabsorbed, and urobilinogen excretes as urine. %80 excretes as stercobilin, and 20% excretes as urobilinogen. So unconjugated bilirubin is lipid soluble and water soluble, insoluble. It is bound to serum albumin. It is not excreted in urine. Conjugated UDP glucuronidal transferase UGT1A1. This it is due to UDP. Conjugation occurs due to UDP. Unconjugated bilirubin is lipid insoluble and loose soluble and tight bondness with serum albumin. It is not excreted in urine. Just a second.